I'm going to be talking about patient-centered communication, which is a slight different approach than what we've been hearing from the epidemiologists. And I'll be very frank to begin with. As an ethicist, what we do is qualitative research, which means our numbers are very small, but we still get very interesting results. And what I'd like to do for us today is first define patient-centered communication, because it's a little bit more complicated than I think some of us may think. I'm going to present a few studies that demonstrate that it actually does, good patient-centered communication does impact outcome. Go through a few of our own studies and talk about some loose ends and next steps. So what are the domains of patient-centered communication? It's not just information exchange, which is what I think we usually think of. It's also interpersonal, building healing relationships and responding to emotions. Then it is information exchange, which is doing good communication about what the facts of the case are. But there's also an organizational component, which allows, if the organization is well put together, it allows the patient to do self-care. So interpersonal kinds of questions are, the patient will say yes to these. I was treated with sensitivity and respect. I felt known as a person. I felt listened to. And here's a tough one. My cancer care team helped me cope with difficult feelings, fear, anxiety, and feeling down. The next one, information exchange, is the one I think we're more familiar with. This is shared decision-making. We hear a lot about that. I think the best 6 steps of shared decision-making actually come from Richard Brown with some modifications by Baumhoff-Roderick. First of all, you explain the patient's situation, you explain the treatment options, you give the patient plenty of time to respond, think it through. Here's the controversial one we'll talk about later. You make a recommendation, then the patient responds, and then you do the implementation. Organizational is things like, I knew whom to contact if I had a question. I also knew how to contact if something had gone wrong. And I think Winship is good at that, but we have not studied that. So let me give you some data on why some studies, there are many, that show that patient-centered communication actually impact outcome. This was a study of 1,722 men, 3.5 years after a radical prostatectomy. The patient was surveyed every 6 months. And they also, the urologists were providing medical data at the same time, and treatment adherence actually improved with shared decision-making. We found the same kind of study with adherence to tamoxifen and breast cancer. Again, it was a medical record review and patient survey, and after 4 years, patients who had less support, less shared decision-making, did not do as well on treatment adherence. Treatment initiation as well has been shown to actually improve with patient-centered communication. This was another breast cancer study comparing African-American and white women. They collected the data by phone interviews and medical chart review. And actually, when participants reported greater physician communication, they were more likely to start chemotherapy significantly. As we heard in our last talks, Black women might have had a longer time to initiation, but still patient trust was significant in whether and when they initiated treatment with chemotherapy. This is an interesting study. This compared 13 RCTs. Each of these randomized controlled trials trained physicians in one aspect of patient-centered communication. And then they compared the control and the trained group with outcome, and the outcome depended on the trial. It was like pain, depression, blood pressure. And there was a small but still statistically significant outcome improvement with the trained physicians compared to the control group. So what has ethics been doing? The ethics team has been very embedded in the phase 1 unit for obvious reasons. This is a difficult time in a patient's trajectory, and ethically we want to make sure that absolutely everything is patient friendly, and the phase 1 unit has been just wonderful working with us on this. Couldn't have a happier relationship. And one of the things we wanted to look at was, we always say consent is not a one-time thing, it goes over a process. We wanted to actually see if that was true. So we audio recorded and transcribed 38 conversations about phase 1 trials. And sure enough, phase 1 trial discussions occurred at 4 different times. But that's not what is important for the talk today. In this study, we also looked at some PCC, patient-centered communication traits. Information exchange was done well. 68% the patient was given time to think. They asked for questions 66% of the time. They checked for patient understanding a little less frequently, 23. Interpersonal, we also looked at, and amazingly, almost half the time the physician assured the patient that he or she was going to be honest about this. And you can understand that because this is a difficult time in the patient's trajectory. And there were times when the physician needed to comfort the patient, since it is a difficult time, but that was more frequent, 16%. Another study we did where we looked at patient-centered communication was, we were answering an ethical concern. The ethics community, excuse me, some have argued the physician should not make recommendations because that will hurt shared decision-making, because then the patient will feel like they have to do what the physician recommends. Our experience at Winship is just the opposite. Patients want recommendations, and it helps them think through what they are going to do with their treatment. It helps them in shared decision-making. So we actually, again, sat in on and audio recorded and qualitatively coded 23 patient-centered, and actually it was just a certain kind of phase 1 conversation, 23 of them, to see if you could make a recommendation and still do shared decision-making, and the answer was unequivocally yes. When the provider made a recommendation, they still went carefully through the steps of shared decision-making. And here's what's important for today's talk. Doing shared decision-making is very well done at Winship among those 23 conversations. Every single provider presented the patient's present situation. Every single provider explained the treatment options. Almost all gave the patient time to react. And making a recommendation, it depended on the circumstances. Sometimes the recommendation was not required. Not as high a response in having the patient respond, but that might have been just the patient's. And 100% of the time, the physicians then went forward and did whatever the decision was and made the next steps. So the information section of patient-centered communication, I think, is done well. Both of our studies show it's done well among our providers. So now, next steps. So we're also curious about how this interacts with trust, because that's big in the literature. We saw that in one of the previous reports, one of the previous talks today, whereas trust did not impact enrollment. But it is something to think about. And the other one is, can we improve the interpersonal domain, which we have not focused on in the ethics group at Winship. So there is evidence that physician communication style does improve patient trust. And this was a study by Aurora of cancer patient survivors. They were surveyed about the physician communication style and their trust. And definitely, if the provider had good communication style, the level of trust went up. Another part of this, which we think is important, is that if patients are trusting, it might increase enrollment in clinical trials. And this is actually a small study which showed that it was a big part of whether you enroll or not is whether you trusted your doctor. But here's what I think is very fascinating. At Winship in Georgia, as we heard, 32% of Georgia residents are African American. 20% of myeloma patients nationwide are African American. At Winship, enrollment in myeloma clinical trials in the last 2 years was 33% African American, and enrollment in phase 1 myeloma trials was 35%, whereas the national average is 5%. So as an ethicist, you go, okay, what are we doing right? Can we share this? These are wonderful statistics. We clearly are communicating or doing something well here. What is it? So we've designed a study, which we're waiting for funding for, where we're actually going to ask the African Americans on myeloma clinical trials about trust using a standardized trust scale. And since we will be doing this study, we'll also use a standardized comfort scale, harms and benefits scale, and other things as well to address some of the other issues which may be a factor in why we are doing so well. And our goal, of course, is to be able to share this with the other national sites who are not doing so well, so that we can increase enrollment, so we can overcome disparities, because as we've heard and as we will continue to hear, not enrolling in clinical trials can contribute to disparity. Okay, so what about the interpersonal domain? There's lots of literature out there that says that even physicians who do good in the information sharing domain of communication may not do as well on the interpersonal domain, sharing the emotional and social needs. And I just mentioned one study here of a little over 1,000 cancer patients where only 29% said that the physician did a good job on that. We don't know what's true in our greater experience here at Winship because we have not focused on that domain. But I think one of our future studies should be to assess it, and if it's lacking, to work with experts, many of whom are being talked about today, are on the panel today, to design an intervention, because patient-centered communication, all three domains, are very important to patient outcomes. We've shown that. So we must constantly work to improve it. And even though we're hitting it out of the park on the information exchange, we should be able to do the other two domains as well. And maybe we do, we just don't know. So I really want to thank my ethics team for helping me with this presentation, Margie Dixon, who's my senior research coordinator. We are privileged to have 2 ethics fellows this year who are the backbone of the program, Claire Seibold and Shannon Blee. You can reach me with questions at my email shown here on the screen. And now definitely open to questions and to turn it over to Colleen next.